Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. I'm so glad you have chosen to listen in on our discussion about the importance of checklists, specifically surgical checklists and the prevention of surgical errors. Joining me for this discussion on the prevention of surgical errors is Vanjie Dennis. Vanjie, I am really thankful that you are here, that you are taking time to share your expertise with me and our listeners. Can you share a little background on how this became your area of expertise?
Sure. My background, I've been a nurse for 40 plus years, but just very passionate about nursing in general. And specifically, my specialty is periop nursing. I went the regular channels where I became a floor nurse for a while, bedside nursing and ICU nursing, and then just fell in love with the operating room and moved into this position, been in a leadership role for almost 25 years.
Wow.
Where it encompasses the full spectrum of periop nursing. Because so many times people think it's just surgery. And specifically, we talk about surgical checklists, a lot of the beginnings start in the pre-op phase or the surgical assessment center. It encompasses the whole spectrum of patient care.
Wow. So I have not spent much time personally in the operating room, but I've recovered quite a few in the ICU. But I don't have a lot of experience in what you're going to be talking about. So I'm really going to be learning a lot from you today and taking in a lot myself. So I'm really excited about that. And I was really, oh, absolutely. And I was really preparing for this discussion. I felt like I needed to know a little bit more to be able to have this discussion with you. And so I started looking at evidence-based articles and specifically around checklists and like patient outcomes. And I found some from all the way back in 2013. That really identified the implementation of checklists and how they improved post-operative mortality and morbidity and emphasized communication and teamwork. And I know I get frustrated when you hand me another piece of paper or another step or, another checklist, really. But surgery is so different from any other nursing role I have ever been in or seen. And I know that patient safety within the operating room is so important. So I'm really excited to tap into your knowledge today.
Thank you.
Oh, yes. And I think a good place to start is going to be, can you tell us kind of that difference of working in an operating room versus other bedside areas in healthcare and how critical patient safety is and how that checklist came about?
Yeah, absolutely, Candace. It is a lot of people, one of the ongoing jokes with my peers, it was 4 executive directors or AVP when I was in the Atlanta area, and they go, well, perioperative nurses count instruments and organize. We always had a running joke with that. I said, no. It is a very complex service line. And I say this respectfully, I can get acclimated to the floor fairly well and jump back in. I've been trained in that in school as well as you have. But going into the operating room or even the pre-op, post-anesthesia care area incorporates every component you can imagine of your nursing practice.
Right.
And with that is coupled technology, which can make a big difference in the outcome of our patients. I think I'd love to just give our audience a brief overview because as you and I dialogued prior to this, surgical checklists have actually been around a long time, and it wasn't necessarily initiated by the WHO, the World Health Organization. And I thought, as I started doing my own research, the development of checklists from a professional point of view actually ties back to the aviation industry. And
I can see that. And I see that because my husband is in the aviation industry, and so
he's probably very familiar with checklists.
Yes.
But this was as early as the 1930s and the 40s. And looking at that, what they found is even in your most experienced pilots, their results or outcomes of mistakes, I don't really want to call them mistakes because nothing was intentional, believe me.
Right.
They were the ones that had the highest incidence of mistakes. And it's extremely complex, as your husband can attest to. But what happens is called normalization deviance. We talk about that in our perioperative practice. But when you perform the same task 100 times, and that's in surgery, hello, time out, everybody being quiet, and then we're going boom, 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 boom down the list. And somehow we're doing nothing but focusing on the list instead of the real outcomes of the list. Sometimes can be very scary. And that what happens is you fall into a certain sense of complacency and really don't double check. So what the aviation industry did is so we would not forget those critical steps, and they're very unique to the service that we're performing on a patient. They develop a series of safety checklists. And we incorporated that into peri-op practice is what we did, as well as other parts of our nursing specialties.
Yes. Well, I knew that aviation had checklists, but I didn't know that we were connected to, where that idea came about goes all the way back to aviation. So that's really neat to see how the two industries kind of intertwined for safety.
Absolutely. Yeah. A lot of the things we've adopted have actually been through industry. So what is a surgical checklist? I think we all know this. It's intuitive if you've been in nursing. It is to improve the procedure that you're doing, whether it's on a bedside procedure or in the operating room, to perform key safety checks during vital phases. With perioperative nursing, our phases come into 3 phases is what happens. And this was initially came on board in the year 2007, where the WHO, the World Health Organization, patient safety, launched their second global patient safety challenge. Safe surgery saves lives. You've heard it. In fact, we actually have, I think it's June 6th, but don't quote me on it, please, because we got so many dates we celebrate.
Yes, look it up.
Yeah, but it's actually, we have what we call timeout day, where everybody in perioperative nursing is to become aware of national timeout, which is basically a checklist. It's just the perioperative checklist, which is pretty cool.
Like a reminder, just maybe remind them how important it is to do this so that it doesn't become white noise.
Absolutely.
Maybe the intent behind that day.
I beg your pardon?
I was going to say the intent. Maybe that's the intent behind that day.
Oh, absolutely. Whether it be Perioperative Nurse Week or your boss's day, it brings that awareness back. But it is actually, with 48,000 members of my professional organization, the Association of Perioperative Nurses, it is everywhere. You see everybody emailing and texting, happy National Timeout Day. So we are very aware of the criticalness of embracing timeout or the surgical checklist.
Right.
And who does it incorporate? So what makes perioperative different? I'm not a bedside nurse, so what I'm going to tell you is what I know. Okay. And it incorporates the entire team. Whether we are doing a block in post-anesthesia care unit or we're in the pre-op area and the surgeon comes in, that would include anybody that's part of that specific procedure. So that could be the surgeon, that could be your anesthesia provider, that could be your anesthetist, and that could be the nurses as well as the surgical tech. And it's to perform key safety checks during the vital phases of peri-op nursing. So that could be, again, in the pre-op area. It could be prior to induction of anesthesia. We even go into detail where they may go in prior to the skin incision. Before the team leaves the operating room, it could do that. Or if they're doing a block, like I said, in post-anesthesia care unit.
Now, when I worked on the bedside and I was on a heart floor, I was on right before it was a patient who was going up for open heart surgery. And, we had checklists for him that, you started the night before with his Hibiclens and the showers. And then that checklist continued up with him to pre-op and so is that the continuation of the actual OR checklist? Is that the start of it?
I believe it's part of it. It's the start of it. And it wasn't, well, it was a pretty long time ago, but I remember that where on the front of the chart, we didn't have electronic documentation. I had a checklist to assure all this components prior to surgery was done before we wheeled them back.
Jewelry off. Yes, jewelry off and, a gown on. And yes, and it was a full checklist, and it was not electronic charting, just like you're talking about. It was paper charting. Yes, but I see that as that start of the checklist, the start of making sure that what needs to be done is done. Okay. So
go ahead. I apologize, Candace.
Oh no, it's okay. Who is the main role, the main player in developing these checklists?
The checklist actually, when you talk about where did it begin, it was the WHO patient safety, the second global patient safety challenge. Safe surgery saves lives. And respectfully is when there was an increase in wrong site surgeries. Do you remember all that came about national news? Oh my gosh, or when radiology uses radiographic marking to indicate where we do surgery. If it's flipped or slightly reversed, you can end up doing the wrong side. So it kind of evolved, and we're not all, I always kid, I say this to my team, we're not all Netter's textbook model. So what makes surgical checklists so different, you have got to look at the complexity and the type of procedure you're doing, and what if there's a magnitude of surgical specimens and we have to notify the team that there will be a certain type of specimen retrieval? Because if you lose a specimen or forget to get it, that is a definitive diagnosis and can make the difference in the patient going back. So it's very complex because it incorporates just not the procedure you're doing, but all this equipment around. Or what if you're in the airway? We got to have oxygen to live. You're intubated, but oxygen leaks around the area. And then now the 98% of our preps are alcohol-based. And if you don't let them dry, you end up with a surgical fire that can be very debilitating and even create death in some patients.
Right.
So all that checklist is, even though we have standardized components of it in surgery, whether it's positioning or whatever, we will expand on it on the given situation of the criticality of the procedure we're doing and some of the patient's comorbidities.
Right. So I've worked with quite a few surgeons in the ICU, and they're usually very short on patients, very short on time. And so really, how do you know kind of when the checklist came about, how accepting were they at first, or, even the team as a whole, how accepting it was, how easy it was to get them to start to work on the checklist and to maintain the checklist and.
Oh my goodness. Culture is very hard to change.
Yes.
Potter has this theory on what it takes in the steps of culture, and I can't tell you that off the top of my head right now. It's in one of my lectures, and to incorporate a cultural change. And in the beginning, they were reluctant, and I don't know whether they didn't understand, and our team was too. I can't blame it on the provider. We do this all the time, one of those things. I know how to do this. And it took a huge culture change, absolutely. And doing that is, how do you get a culture change? It takes 2 to 3 years. So when our professional organization and our regulatory, as well as our accreditation bodies came in, they started putting a tremendous amount of focus on correct delivery of timeout or surgical checklist. It's a very big focus. So I think it's important to do that culture change. And you talk about reluctancy. You have to engage actively the stakeholders. You also have to develop your tools and your processes to support the implementation, because docs are scientists. And when you start looking at wrong site surgery, or a good example is if we're closing and the surgeon goes, well, I know how much sponges I have. And lo and behold, you leave a sponge in and got to bring the patient back. It really makes a believer in them. I think, too, is institutions have to set clear expectations for accountability. And that accountability is not just our surgeons. It's our nurses and techs that are in that room. And making that checklist part of our overall culture.
Absolutely. And I did study Cotter, actually. I actually taught, also I pulled Cotter into some of my leadership teaching. So very familiar with the culture change. And I think the military, some of the leadership use that as well when they're trying to make changes. So very well known. If you haven't seen him, I really encourage going and looking at that theory. He's got some really great theory on culture change. But all right, so who's responsible for ensuring that the checklist is done?
I love that question. I get that a lot when I teach. I'm a teacher by nature. I said, don't look at this time. I'm really a teacher. I think it is a team approach.
Okay.
It used to be the infamous saying, I know you remember it, the captain of the ship. The captain of the ship is no longer. And if a patient is in the potential for imminent danger, we should all be able, no matter whether it's peri-op services or the bedside, call a safety stop. So we do set a standard operating procedure who will call the timeout, but it's not necessarily the surgeon that calls the timeout or the checklist. More times than not, because the surgical tech is so covered up with getting everything set up, it is usually the circulating registered nurse in the room that will initiate the checklist or timeout in that room. When that occurs, and I think this is real important, I was at Emory for 7 years, you have to enforce that everybody stop what they do. No music in the operating room, no talking, and we all go over that collaboratively together. And there's silence in that room. And when Joint Commission or D&D or AAA Quad A come into these operating rooms, they do look for that. Everybody has to stop. So it's usually the nurse.
The regulatory bodies really do play a role in accountability. And what about development of, because I figure, is it a standard checklist or, does each organization have their own spin on the surgical checklist?
I think that's an excellent question. When we start getting into completely standardized, that's where we get into that normalization deviance. I think you could agree with that. Everybody's doing it the same way. And I always say it's kind of like when you drive your car, you know where everything is, and the car knows how to get you home. But if you get a rental car, I am so confused. Where are the lights? Where are this? So in short, to answer your question, we have templates, whether it be from the WHO, and I have an excellent example I can send and share with the listeners. If you want it, I can email it to you. But you don't necessarily do, it's not necessarily created specifically for the culture of the type of services you have. Example, Association of Operating Room Perioperative Nurses has a example or template of a comprehensive surgical checklist where the WHO may have just a checklist. So what we did within AORN is we incorporated the WHO, the Joint Commission of Universal Protocol, as well as a combination of other national patient safety goals. So you make it your own. Or, for example, if you have a center that does primarily pediatrics, your checklist is going to be very different from maybe an adult hospital system. So they're actually customized using the basic templates from the WHO or from AORN.
And this is such a random question, and maybe it's more of a rhetorical question, but I wonder how many iterations came out before they got it right, before they felt that this was the checklist?
I can't imagine.
Yeah.
Really can't. Yeah, because I know within my time as a perioperative nurse, over 45 years, and then the implementation of the checklist, I've seen a lot of different versions. In fact, when I first came here, I noticed, because they didn't do a lot of lasers, I'm certified in lasers, a lot of fires, things like that can happen. They're highly regulated device. And I said, we're not incorporating the checklist of fire safety. And we would even get to the point where we do a visual means of putting something at the door and you flip it over that says this was high risk for fire in the OR. So good example is I came to this hospital, been here 3 years now, and implemented that as part of the checklist.
Wow. Yeah. It would be very interesting to just know how many iterations came about, because I know just in our careers, you see so many different changes and so many different iterations to anything that we do to get it right. Do you happen to have any data before we had the checklist and then after that checklist, made it through that culture change and was actually being used the way that it was intended?
I have a little bit. I did some research in preparation for this because, as nurses, it's hard to get those statistics right off the top of your head.
Right.
And estimate shows that I'm looking at some of the notes that I put down. 234 million major operations were performed every year. And one for every 25 patients in the world itself was affected by some kind of outcome not doing the appropriate checklist or safety. Surgery had a high rate. We were stand out. I think that's why we have National Timeout Day.
Right.
Morbidity and mortality, at least 7 million people a year experience some kind of disabling surgical complication and more than 1 million die. That's pretty significant.
That is.
So the Safe Surgery Saves Lives strategy campaign strived to promote the surgical safety as a public health concern. And that's when we saw them morphing more and more different types of checklists. So looking at when the WHO, and I think that's the baseline they used, came out with their recommendations on a surgical checklist, specifically, it reduced the rates of death and surgical complications by more than 1/3 across 8 pilot hospitals. That's pretty significant.
It is.
And the rate of the inpatient complications dropped from 11% to 7%, and inpatient death rate following the operations fell from 1.5% to 0.8%. And there's many theories around that of what do you think helped to make it a safer, and it's multifactorial. It's probably the checklist, the pauses, the slowing down a little bit with the uptake of technology. I have to even say that to my boss. We've got to slow down. This has got so much stuff in the room. And
do no harm. Bring it in slow. Do no harm.
Oh, absolutely. But you've got people doing the calculations. Again, I'm saying this respectfully, at OR time being $47 to $57 a minute. They're going, we got to decrease our turnover time. We've got to do this, but not to the extent of our quality in taking care, because we are in the people business.
Absolutely. With the checklist, what are the key components of that checklist? Like a typical
Let's start
surgical
off with
checklist.
the WHO.
Okay.
Yeah, well, let's start off with the WHO. They have 10 objectives for safe surgery because we use that as our model. And the first objective is we will operate on the correct patient and the correct site. Number 2, we will use methods or methodologies to prevent administration of anesthetics while protecting the patient from pain. It's, like I said, it's huge. The team will recognize life-threatening loss of an airway. We have to start bucking on that tube, or if they're extubated too quick. The team will recognize and prepare for the risk of blood loss, or avoid allergic or adverse response to a prep or medication. That's part of the checklist. A good example. Are you allergic to any iodine? Well, that's something that may not be picked up on in pre-op, but if we prep an iodine, we're going to have a complication with irritation in surgery, and that's the last thing they need.
Right.
We're going to minimize the effects of surgical site infection. So here's another example of surgery. The antibiotic has to be given as close as possible to the time of the incision. So you can't give an antibiotic in the pre-op area if they're waiting an hour to come back. So it is done in surgery. And then there is the counting. We have 3 stages of counting instruments. So the team will inadvertent retention of surgical instruments and sponges. And then they'll identify specimens. Specimens has gotten to be a big deal, where if you throw away a specimen, as I said earlier, that's definitive diagnosis. That's a problem. They'll secure effective communication, where we want a relaxed situation in surgery, but you don't want the radio going loud and people talking over each other and not paying attention. And a good example of my heart team, I said, when we go off pump, there's no conversation. It is only led by our heart surgeon. because that's such a critical time for the patient.
Right.
And systems, us specifically, should incorporate established surveillance of our capacity, our volume, and the monitoring. Are we doing this correctly? Because we don't want to get in a routine to where we just check the box and not really pay attention.
If this was not on a computer, how many pages would the checklist be?
Our checklist is, I'll give you an example. I have one that I can send you. It could be 1 page, but the font's probably a 2, and you got to wear your glasses to see it. If you want to keep it in simple terms, instead of trying to incorporate the pre-op checklist with the interop and the post-op, it needs to be its own entity. So you could do it in 1 page. You really could.
Okay. Did you have another? I know we talked about the who as far as the typical components of a checklist. Is there another one that you wanted to touch on?
Well, I did AORN.
Okay.
The Association of Perioperative Nurses, where everything that the WHO is saying, because remember, the WHO is designed for surgical safety checklists. So when you look at our association's template on what they recommend with surgical safety, it's not any different really than the WHO, to be honest with you. I'm looking at it right here. I got it in front of me, and it really, it incorporates everything that they recommend. We may expand and take it a step further to not get so, the terminology for the staff in the room where we may say, are they allergic to any of the prep? We'll get specific. There is a potential fire issue. We are in the throat. We need to look at the anesthetics and gases and keep the oxygen as low as clinically feasible. They will go into that more detail in that checklist.
So to touch on the OR team a little bit, trying to really understand the collaboration and that communication aspect between all of the healthcare team and those really important pieces. Within the OR, it seems like the entire team is going to have to adhere to this surgical checklist and play a role on that surgical checklist. What does that look like?
Okay. If I had to reiterate what would actually happen, and let's say we're going in and we're doing a trach, in there. So as we go in and the patient begins the induction, which is prior to when they start the induction, we will begin the surgical checklist at that time. They call that the timeout. They call it their own little name. Remember, National Timeout Day. And they will begin to identify the patients that RN will signal the team. The team will then quiet down. The anesthesia is still going to give anesthesia, but they're going to be paying attention. Okay. And we're going to identify the correct patient by 2 indicators. So, same thing that you do in the bedside.
Right.
And then we're going to go specifically and talk about the prep. This is, we're not going to be using any flammable preps. We're up near the airway there. We're going to keep the oxygen as low as possible, as clinically feasible. We are going to actually focus very much on that procedure with the checklist. There will be several specimens. Well, with the trach, there's not. But if there's an incision on the neck and you require specimens, we would announce that during that timeout. Their blade, nothing will be passed until those indicators are completely reviewed during the surgical procedure.
Yeah, that's a lot. I mean, that really holds the whole team accountable. You don't do anything until we get through this, and everybody, it's almost like call and roll. I'm here.
It is.
Everybody's here. I've done my job. I've done my role. All right, we're good to go. We can get started.
Yeah. They'll even ask about the antibiotic. Have you given the antibiotic yet? Yeah. Close as possible to the incision. 1 hour prior to the incision or as close as possible. Absolutely. Even the sterilization indicators could come into that. We may have multiple trays in the room, and they'll make sure that the indicators and everything are the trays are at the point where we can use them without any potential complication to any contamination.
It's very, very extensive. Well, Vangie, we've come to the end of our time for episode 1, but I'm hoping when we start episode 2, you're going to be able to share maybe some real world examples of where sticking to that surgical checklist really made a difference. Got some of those for us for episode 2? Okay. Well,
Thank you.
I've learned so much from you just in episode 1, and I'm looking forward to gleaning some more knowledge from you in episode 2. So to our listeners, I hope you will join us for episode 2 as we continue our discussion on patient safety and checklists in the OR.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.